So first of all, thank you everybody for attending tonight. I would like to acknowledge that we are meeting on Aboriginal land over here in Western Australia. We're meeting on Whadjuk Noongar country, which is where Carissa and I are. And we've got panelists in Melbourne who are on Wurundjeri country, and Kirsty, you have to help me out here. I don't know.
Oh, Ghana.
Ladies, sorry?
Ghana land.
Ghana land.
Yeah.
And in the spirit of community, we're meeting today to support each other in supporting people who need the best treatment and our endeavours to get there. So with that in mind, I'd like to introduce our panellists today. We've got Professor Andrew Chanin. I'll get you to say hello, Andrew.
Hi, everyone.
Professor Chanin is going to be talking today about youth early intervention and general treatment for BPD and the latest research in that area. Professor Chanin is very interested in prevention and early intervention for severe mental disorders, principally personality disorders, along with mood and psychotic disorders. He developed and directs the award-winning Helping Young People Early program, a clinical research and training program run out of Orygen that is focused on understanding, preventing and treating severe personality disorders in young people. He has been the president of the International Society for the Study of Personality Disorders since 2011 and an executive board member since 2003. He serves on the editorial boards of early intervention in psychiatry, psychopathology, personality and mental health, and is a reviewer for local and international scientific journals. Andrew's research includes the published first randomised controlled trial of early intervention for borderline personality disorder in young people, and he is also a board member of NEA BPD, which is the National Education Alliance for Borderline Personality Disorder, which is bringing you this webinar today. And just while I touch on the board, I'd like to acknowledge the board members that are here today, and also our founder, Anne Reeve, who I believe shanghaied Andrew into becoming a supporter of NEA BPD, and just acknowledge her passing last month. She was a great loss to the BPD community because she was a force of nature who got things done and was a passionate advocate for people directly impacted by BPD, either themselves or in their families, and in terms of really getting the word out there about the best treatment. So I'd like to honour Anne today. I'd also like to introduce Dr. Yogi Agrawal. You want to say hello, Yogi?
Hello.
So Yogi completed his specialist training in India, and he obtained a fellowship from the Royal Australian and New Zealand College of Psychiatrists in Australia. Dr. Agrawal currently works with Monash Health in the Youth Mental Health Early Psychosis program and has been in private practice in Gippsland and Melbourne since 2009. Prior to this, Dr. Agrawal has worked as a consultant psychiatrist in Latrobe Regional Hospital, Latrobe Valley and Sale Community Mental Health Service for more than 11 years. He is an adjunct lecturer at Monash Rural School of Medicine and is involved in teaching medical students and trainee registrars. He's particularly interested in working with GPs on primary care. His areas of interest are mood and anxiety disorders, borderline personality disorder, perinatal mental health, and organic and functional psychotic disorders in late adolescent and adult groups, and he'll be talking to all of those subjects today. And our final presenter is Carissa Wright. Can you say hello for us, please, Carissa?
Everyone.
So Carissa Wright is a peer facilitator based in WA. Carissa has worked nationally in the BPD space for 4 years now. She's also a member of our board and has shared her story and advocated for change in spaces. Carissa is a peer ambassador for SANE Australia, works closely with BPD Australia and is a member of the NEA BPD board and runs her own peer support group called Embracing BPD. In 2018, she also spoke at the very first BPD event in New York with an organisation called Emotions Matter. Carissa's main interests are sharing of lived experience, peer support, and dialectical behaviour therapy. And are you still writing for The Mighty, Carissa? You wrote some articles for them early on, I remember.
Yeah, I haven't wrote for a while, but I'd like to get back into that when I've got time.
You write very well, so I think you should.
Thank you.
Yeah. Okay, so we'll start with Andrew. I'm going to hand over to you. Oh, sorry, no, I'm not just yet. I forgot the Q&A format. So as questions come up during the, you're bound to think of things. So along the bottom here, you've got chat and Q&A. If you can post the questions in Q&A, then if we can answer them during the presentation, Kirsty is our question wrangler. She'll put that through. So if you can put those in the Q&A format, but if you don't, that's fine. We'll find them in chat as well. And Andrew will speak for 20 minutes and then we'll have 10 minutes for questions. Then we'll go to the next presentation and then another 10 minutes of questions. And then whatever time we have left at the end, we will answer general questions. And yeah, and this webinar will be up tomorrow on bpdaustralia.org. Okay, I think I've got it now.
Okay, well, thank you very much, Jenny. And I too would like to acknowledge the traditional owners of all the lands on which we all meet this evening, and their elders past, present and emerging. I would also like to dedicate this talk to Anne Reeve, who as Jenny said, certainly wrangled me, and Anne was somebody you never said no to, and I was grateful for never having said no to her. So we will miss her terribly, and she made a wonderful contribution to NEA and to families and people with lived experience of BPD across the country. I've got no conflicts of interest. I am speaking in part about the work of the HYPE program in Melbourne, and I do need to acknowledge this is a very limited list actually of people to acknowledge. I'm standing on the shoulders of many people, and you can see some of their smiling faces there, but I have a wonderful team, and I would particularly like to acknowledge Louise McCutcheon, who I think is on the very left of your screen in the red cardigan, who has been my co-pilot for the entire time that I've been doing this work. So this might not come as a surprise to any of you that late intervention is routine in borderline personality disorder. We delay making diagnoses, we only offer specialised treatments, and only very late in the course of the disorder. We usually offer them reluctantly, usually to very few patients, and only those who we deem to be well behaved enough to take them up. And there's no coordination of the service system. And sadly, we only start helping people once their disability is well and truly entrenched. And there's a very strong focus, I would argue an excessive focus, in the across the mental health system on individual psychotherapy as the only form of treatment. I'll say a bit more about that later. And sadly, many people are harmed by their experience of the health system, not helped by it. So why would we engage in prevention and early intervention for BPD? Well, BPD is really a synonym for severe personality disorder, and our interest in HYPE in BPD is not really around the narrow syndrome. It's really that the features of the disorder are simply a red flag for a group of that describe a group of people who have a very high risk of having a poor outcome in life. And the reason to intervene early is to try to prevent those poor outcomes and to help them to grow into adulthood and to thrive. So we also know that one reason to intervene is that even early on, and this is work from my colleague Sue Cotton, my collaborator for many years, and this is literally hot off the press. We only got the data a couple of days ago. That compared with families who care for a loved one with first episode psychosis, those who care for young people with BPD experience more negative experiences of care, less positive experiences of care, and higher levels of expressed emotion. Kind of negative experiences include stigma, problems with services, effects on the family, loss, dependency, a whole range of negative experiences. And so we know that actually by any measure, borderline personality disorder is associated with incredible effects across families and the individuals who have the disorder. It's not a normal part of development. There's a bit of a myth that somehow borderline features are normal in young people after puberty, and it's associated with a high burden of mental health problems across the range. So having personality disorder puts you at risk for developing depression, anxiety, eating disorders, all sorts of problems, and of course, especially self-harm. And really importantly, it's associated with severe and persistent functional disability. And this is something that persists well beyond the features of the disorder. And one of the untold parts of the story of people with BPD is that they have poor physical, sexual and reproductive health, much poorer than their peers. And that's often due to lifestyle factors associated with the disorder. I think this is the most damning statistic about BPD, that service users, that is patients, and that's what this study was of, with severe personality disorder live 2 decades less than their healthy peers in the community. This is a disorder that comes on early in life, is associated with persistent disability and then with premature death. And that makes it a huge source of disability in the community, one that we need to prevent. So who are we targeting? Well, there's international consensus that you can diagnose BPD from around puberty, but this focus on what's called adolescent personality disorder really ignores the developmental continuity from puberty through to about the mid-20s. And that this period is a period of particular vulnerability, not just for BPD, but for all of the major mental disorders. So we can't think of BPD separately to other mental health problems. We need to think about prevention across all disorders. And one of the problems that we face is that when people think about prevention, they don't include personality disorder in their efforts. And so early intervention for BPD really needs to be a core part of the youth mental health system. We've just finished a study that's under review at the moment, showing that when you compare younger people with BPD with older people, they are much more common than they are different. And there are substantial similarities across 20 different aspects of their presentation, the diagnoses they have, the levels of substance use, suicide attempts, all sorts of problems. And there are some differences. It stands to reason that between the ages of 15 and 25, there will be meaningful differences between people. But those differences guide the way we might think about delivering services. They don't suggest that we should separate these groups of young people. And importantly, early on, the younger group actually have higher rates of self-harm than the older group. And prediction of the older group membership is actually vocational disengagement, that is, not achieving educational milestones or dropping out of school or work. So there are meaningful differences between these age groups. And what's the threshold for intervention? Well, you'll all be aware that people think of borderline personality disorder as a diagnosis, and you have to get 5 out of the 9 criteria in the diagnostic manual, but actually any BPD features are associated with poor health-related quality of life, symptoms and distress, high usage of mental health services, and poorer functioning. So it really challenges the meaningfulness of these arbitrary diagnostic thresholds. And if you wait for somebody to present with the full syndrome of BPD, much of the developmental disruption and damage to future prospects has already occurred. So we need to get in much earlier in the developmental course of BPD. We also know that actually the features of BPD, the diagnostic features, get better over time, whether you do nothing actually, or whether you intervene. Now, the time course for them getting better is too long, and the risks from some of those features are too high. But that's contrasted with a feature, it's really not a feature of the disorder, but a kind of phenomenon that comes from the disorder, which is that the impairments in social and vocational functioning actually persist, even when the criteria of the disorder wane and people no longer meet the diagnostic criteria for the disorder, and they persist for decades. This is a Danish study. When you compare so-called first admission borderline patients, that is, people who are presenting for the first time with BPD, they have 1/3 lower odds of being in work or education compared with any other psychiatric disorder, all other psychiatric disorders. So this disorder comes on early and has long-term ramifications. And the interpersonal and vocational problems associated with BPD are often overshadowed by this short-term focus on the features of the disorder, and particularly on self-harm. And I'm not suggesting that self-harm is not important, but it tends to overshadow what I would say is the ball in the game, which is people's relationships and their education and vocational pathways. So what are the principles of early intervention? Well, you need to try and sweep everybody into the tent. You want everybody to be included. You want minimal reasons to exclude people. So we don't exclude people with antisocial behaviour, substance use, all sorts of things that many personality disorder programs would use as reasons not to see people. We accept everybody and then talk to them if it's not working out, and discuss whether the treatment program is the right one for them. You also need to look at BPD as on a spectrum of severity. So we take people who fall short of the full diagnostic criteria for the disorder because their outcomes are also potentially poor. We carefully assess people for the range of problems, not just focusing on the BPD features. And our program is time limited over and over again, and we've had thousands of people through our program. Young people don't want to stay for long periods of time in treatment programs. And early intervention is more than just psychotherapy. We have some people who come in, or the majority of people, everybody who comes in, gets some care, but actually only a minority of people will get the full individual psychotherapy package that we offer, but everybody gets care. And we know from our research that actually all those elements of care are important. So, is early intervention for BPD in young people effective? Well, unequivocally, we can say yes. There are 8 high-quality clinical trials of structured psychological interventions where there's been an active comparison group, so not compared to just waiting for treatment, and that have specifically targeted young people with BPD features and or the full BPD syndrome. And what they show is that a range of structured treatments that are designed for BPD in young people are effective, but they don't show that any one treatment is superior to another. And that might surprise some people. The biggest problem here is not which treatment is more effective than the other, it's that all of them are unavailable in our health systems internationally. And we really don't know what the specific components of treatment, what role they might play in the outcome for young people who attend these programs. We assume that we know what the effective ingredients are, but actually we don't. And so one of the questions that we've asked in our program and that we've researched is whether less complex interventions could be developed that are scalable across health systems. The great difficulty with delivering intensive individual psychotherapy is that it's challenging to deliver that to the prevalence of the problem given that actually about 3% of young people meet the full criteria for BPD, and even more have borderline features. So we have a large-scale problem that we need to address across the health system. And one of the messages, I think, from our research and from research internationally is that the complexity of treatment for BPD has been greatly exaggerated. As I said, there's a strong focus on complex psychotherapies when the evidence doesn't actually support that these are necessarily the be-all and end-all of treatment. In fact, BPD psychotherapies are only modestly effective, and we need to do better than that. What we also know, though, is that structured clinical care, and there are various approaches. We developed the first one, but there have been others developed, that structured clinical care appears to be as effective as so-called brand name psychotherapies, and that evidence-based psychosocial treatments are more effective than treatment as usual. So I'm not saying do whatever you like. You need to be doing structured care that is based on an understanding of BPD. But we know that these various specialist treatments that all have different underlying theories and techniques actually all get to the same place in the end. And so I liken this to laundry powders, because they all get your clothes clean, but they all make various claims on the box, and different treatments claim to work in different ways or to be particularly effective for BPD, but actually there is no evidence to support that. And even the latest, what's called Cochrane Review, which is an independent group that look at the effectiveness of treatments, continues to conclude that no one treatment is more effective than another. Now, you'll all be familiar with a number of the more common psychotherapies, but actually it's the volume of evidence doesn't mean that there's proof that any of those are more effective than the other. So you'll be aware of DBT or MBT, but in fact, they're no more effective than each other or than the other evidence-based psychotherapies. So people often ask the question, what's the best psychotherapy for borderline personality disorder? But I think that's the wrong question. I think the question that we need to be asking ourselves is, how can we intervene at the scale required by the prevalence of the disorder? And how can we fit the health system to the needs of people with BPD, not the other way around? So we have done a trial that we're just finishing. The protocol is published, but we're just finishing the paper for submission, called the MOBI trial. And I won't go into a great deal of detail, except to say that what we did, rather than looking to make treatment more complex, we actually looked at 3 different levels of complexity of early intervention for BPD. And we wanted to look at whether a specialised early intervention model was more effective than a general youth mental health model for early intervention, and what the contribution of individual therapy was over and above the basic model of care that we offer. And then we also wanted to know whether early intervention was effective for emerging adults, that is the 18 to 25-year-old group as well. And what we found was that actually all 3 treatments were effective. And the simplest treatment did not involve delivering individual psychotherapy. So what we concluded was that individual psychotherapy didn't appear to confer any additional benefit over and above high quality care in relation to outcome. And in fact, the highly specialised early intervention service model also didn't confer any benefit in terms of outcome. What the specialised model did, though, was retain people in care much more effectively than the youth mental health model. So to finish up, what I want to say is that we should be looking for BPD from puberty onwards. We should be thinking about BPD when young people present to mental health services, or you should be thinking of that in your primary care practices. The reason to recognise this is that it has a very high potential to disrupt the successful transition to adulthood, with lifelong consequences for interpersonal and vocational outcomes and for physical health. And we know there's strong evidence to support early detection and intervention for borderline features, from puberty right through to emerging adulthood, but we need to integrate the work that we do with endeavours across the world to achieve early intervention for the full range of mental health problems in young people. We also know now that treatment is more than just individual psychotherapy, that clinical care is likely to be effective if it includes a welcoming orientation to early intervention for BPD, that it involves some aspects of clinical case management, and that we address the full range of problems that come in the package with people with borderline features. And we know that it needs to be delivered in a specialised youth-friendly environment, but not necessarily by highly specialised services. So really we're talking about the kind of Goldilocks principle here. We want to not be too intensive, not dismissive, and we certainly don't want to be harmful in the treatments that we offer. So the HYPE intervention that we've developed is scalable across health systems and it can be integrated with early intervention programs across the range of severe mental health problems. And indeed, that's what we do in running our program at Orygen. So in finishing, I just wanted to give a plug for the Global Alliance for Prevention and Early Intervention for BPD. My friend and colleague, Carla Sharp, who's at the University of Houston, would be happy to receive an email from you. And you can join the email list. When we're not in the midst of a pandemic, we usually run events every year, and we also run local events, and people can run their own local event under the banner of the Global Alliance. So thank you very much for your attention, and I'd be happy to answer any questions.
Okay, Kirsty, I see there's some questions coming through. Do you want to?
Yes, yeah. So Andrew, what is FEP? What does that stand for?
Oh, sorry, my apologies. That's first episode psychosis. So that's young people presenting for the first time ever with a psychotic disorder, so schizophrenia, bipolar disorder with psychotic features. So very, very severely unwell people. And the point I was making is that families who are caring for young people with that problem, actually the problems that families with BPD have are even greater.
Great. There's another question, but I feel like this can, it's got an age of 26, but I feel like this can be true for any age. So Anonymous said, is it possible for a male diagnosed at 26 with significant substance abuse issues and challenges with depression to get treatment and lead a normal life, like to maintain a job and relationships? At the moment, medical intervention is focusing on the substance abuse and not the BPD diagnosis.
Well, thank you for that question, because it's really important. Now, the 26 is just an arbitrary cutoff. And absolutely somebody diagnosed with a mental health problem at 26 can get effective treatment and can recover and get on with their life. I think the second part of your question is really important, that traditionally we divide substance use services, drug and alcohol services, from mental health services, and we don't see this as part of the whole package. So when you do studies in surveys in drug and alcohol services, about 50% of people in those services have a personality disorder, yet it's often not addressed. So we need to develop programs that can address both problems concurrently. It is very difficult to treat one problem with ignoring the other. And by the same token, mental health services need to get better at being able to address drug and alcohol problems.
Yeah. Andrew, so Louise White is asking, can you talk to the difference between the structured treatment approach versus treatment as usual? For instance, what are the primary and secondary endpoints of the study?
Yeah, so again, a really good question, Louise, thank you. So the structured approach is actually manualised. It involves having a particular course of treatment where there is a focus on clinical case management, on addressing co-occurring health problems, on practical problem solving, and on addressing a range of problems that the young person brings. Treatment as usual in studies is actually do what you want. And mostly we don't know what happens in treatment as usual. Treatment as usual can be anything from a very skilled and excellent but idiosyncratic practitioner right through to what I have called maltreatment as usual, which is, can be neglectful or harmful care. So you really don't know what's happening in treatment as usual. And so treatment as usual in clinical trials these days is really a poor comparison, because you don't know whether you're comparing your treatment to rubbish treatment or to good treatment or patchwork treatment. And so that's why we think that comparison groups should be structured. That said, my colleague Lois Choi-Kane at Harvard did a review, what's called a systematic review and meta-analysis of treatment as usual, and actually found that it is marginally effective in the treatment of borderline personality disorder. It's got a very, very small effect size, but overall treatment as usual probably isn't harmful, but there are examples of where treatment as usual can be.
Okay. Thank you, Andrew. So Alba has said, my daughter is 16. I'm desperate to find an appropriate support for her. What is the recommendation for treatment in Melbourne?
Okay, well, the general recommendation is to seek out a Headspace service for a young person. And it really depends on where you live, what kind of service you're going to get. So like all of Australia, treatment is a postcode lottery, sadly. And, hence my comments about we need to build a system of care. And you can't guarantee, particularly for young people with personality disorder, that they will get a proper foothold in the system. We still have the problem of lack of recognition of the problem, reluctance to make the diagnosis, and even a deliberate refusal to make the diagnosis because people are worried about the stigma and discrimination that that young person might experience. So I would start with Headspace, which is a very welcoming and open environment for a young person to go to. And we've done a lot of training over the years with Headspace. And they, I think, do have a very, in general, an open, enlightened attitude toward personality disorder. But it is challenging to get services, particularly during COVID.
I like this one in particular. So Monica said, are there any plans to roll out HYPE to public adult mental health or primary care settings?
So not to add public adult mental health on the basis that really the developmental period to intervene in is that 12 to 25. If you mean adult mental health by capturing the 18 to 25, actually what Orygen is really trying to achieve is a statewide and in fact a national and international youth mental health model where services would be from 0 to 11, 12 to 25, 25 to 65 and then 65 plus, where young people would have their own system of care that was dedicated to them. The other part of that was, sorry, I lost the question now, but it was about... in primary care, sorry, and absolutely in primary care. And we think that Headspace is an ideal platform for early intervention for personality disorder.
And Andrew, can BPD start to manifest earlier than early adolescence?
Oh, that's a really good question. So that's the cutting edge of research, and there are, certainly have a number of colleagues who are doing research identifying the traits that underlie BPD in young people under the age of 12 And in retrospect, you certainly can identify that. And there are actually some studies looking prospectively, that is looking forward, that show that you can identify the traits. Generally, the international consensus, though, is that diagnosis should really be restricted until puberty and after, or around about 12 and after. Now, under very special circumstances, you might make a diagnosis in a child, but I wouldn't advocate for that as a general rule. But there's certainly, young people have personalities, whatever their age, and those personalities can have problems, and you can identify those problems early.
Thank you. So is there any evidence that, sorry, they keep moving. Is there any evidence that treatment delayed until mid-20s is less effective than earlier intervention?
Yeah, there is some evidence. When you look at the effectiveness of treatments, there's a method that you can use to aggregate the data for looking at the effectiveness of treatments. And actually the effect size for treatments in adults is not that high. It's not low. I'm not saying treatment's bad, but it's not particularly high. And so if you delay treatment, it is likely that it's much harder to, the way I describe it is, it's harder to unscramble an egg than to prevent the egg breaking in the first place. So it's a general principle across all of youth mental health that early intervention is designed not only to treat the problems that a young person has, but also to scaffold their transition to adulthood, to help them not drop out of the education system, to help make sure that their social networks don't evaporate and that they actually arrive in adulthood with, strong social networks, a strong vocational pathway, and a strong sense of self.
Andrew, so Gary asks a couple of questions. Thank you for your work and time, he says, and some naive newbie questions. But are there early warning signs in young children?
Yeah, so that's not naive at all. I guess that's probably building on the answer that I gave earlier, that certainly there are children who have irritable temperaments, who are difficult to settle, and in retrospect, you can see the roots of BPD. It has long roots into childhood. The difficulty is that not all kids who are irritable and difficult to settle go on to develop BPD. So certainly if a child is showing problems, then I would advocate for them to get help. I think it's very important to seek care. I think we need to be cautious about making a diagnosis of BPD, that's all. And we do know that many of the childhood disorders have a very strong relationship to BPD. So attention deficit disorder, oppositional defiant disorder, these kinds of conduct disorder, they all actually are strongly related to BPD. And that's really because what we're describing are personality styles. They're given labels like ADHD, but impulsivity, which is part of ADHD, has continuity into adolescence and adulthood. And so, we might change the label we give it, but it's still the same underlying trait. I hope that answers your question.
Okay, that was fantastic. There are so many more questions, but unfortunately, we've got more presentations which may answer some of the questions as well. So from a time point of view, I'm going to flip over to Yogi. Thank you. That was absolutely fascinating. I have about 15 questions of my own and I have to. So unmute Yogi. Would you like me to share the screen, Yogi?
Yes, please.
Yeah, okay.
So after hearing a fantastic description and treatment about an early intervention from Professor Chen. I'm talking borderline personality disorder in adult perspective. A lot of things has been already discussed. There would be some of the things would be repetition, but we'll see how it goes. I would apologize in the first hand if this, because I'm not controlling the slide, so there would be some slide lag. I would like to, this is my first involvement in presentation with NEA BPD Foundation, whereas I must thank all of you who have given me opportunity to be part of this group. And I especially thank Terry Hill, who advised me to do this presentation. So coming to borderline personality disorder, as we just heard, it starts from the early life and continues on throughout the life with a lot of problems. It is general prevalence is first 1%, and most of the psychiatric system, it is pretty high, 20%. Although we see a lot of female cases, but it is not well founded. So I believe it is common in both sexes in the same way. Next, please. There's a high service utilization, and as we just heard, there is approximately 20 years reduction of lifespan. So you can see the burden of condition on our system is pretty high. There's a varieties of comorbidities, and unfortunately, we still have limited access to proper treatment. The things are more compounded with lack of awareness about this condition still, and it is a generally an under-recognized condition. There is a general feeling of discrimination, disrespect among the consumers. There's a lack of appropriate services. There's a lot of stigma, sense of guilt and shame while approaching the services, and a lot of other things. Next, please. However, I see it, there is a hope, and this optimism is increasing day by day. If you look at the number of publications, they are increasing day by day, and that itself shows how many people are now interested in this area and putting their work forward. Project AIR, Spectrum, BPD Foundation, and this organization, they are doing exemplary work in raising awareness and supporting patients and caregivers. We can see also increase in specialized service, but of course, there are more in metropolitan region and still more to go. The long-term follow-up studies has further enhanced our knowledge in formulating its management. Next, please. If we look at various studies, long-term follow-up studies, this gives us some kind of positive hope. I mean, I see it in some kind of hope, some kind of confidence that we are now moving towards in some direction. And if you look at all the long-term follow-up studies, please keep moving until slide 12, please. So if you look at these all studies, 12-year, 16 years study, next one, please. Yeah, or review of all the studies, major studies like McLean studies. Next one, please. And the other studies like, yeah, next one, please. Yes. So if you look at all these studies, and there is a meta-analysis which has published recently in 2018, 50 to 70% patient, they achieve symptomatic remission at some point. Younger at diagnosis predicted shortened time for remission. Yes, there would be some kind of a problem in their psychosocial life would persist, but there is a hope. Next, please. Our management system also guided by various studies that include various genetic studies, understanding of neurobiology, understanding of physiological changes, neuroimaging studies, and involvement of opiate and oxytocin and various biopsychosocial theories has enhanced our understanding, and that shaped our understanding of managing patients with borderline personality disorder. Next, please. We see several guidelines has come over the years, and not just in one country. It is from various countries, like NICE guidelines from UK, American guidelines, National Health Authority, Denmark guidelines, Swiss guideline, and most recently, a very encouraging position statement from College of Psychiatrists UK. Next, please. So I'm giving a kind of a evidence-based approaches in managing borderline patients in various heading as a general psychiatric treatment, comorbid psychiatric conditions, crisis intervention, medication, psychotherapy, and some touch base with in special population, such as old age, mother with history of BPD, and involvement of family and carer in supporting BPD patients. So if we look at the general psychiatric treatment, as we understand, we have a lot of difficulty in assessing the specialized, costly, expensive treatment models. But whether we can do still is whether we can work with BPD patients, whatever existing knowledge we have. And my idea is, yes, we can take bits and pieces, and we can still provide a lot of things in the care of our patients. And these things can be easily integrated in the existing treatment services. First thing first, it requires a proper diagnosis and formulation of the case. Without this, other things remains here and there, and that is also very important. Early engagement, welcoming approach gives a patient enhanced hope, and they usually maintain a good relationship, and that become a backbone for future relationship, future treatment. Psychoeducation about diagnosis and formulation of symptoms. There are quite a number of studies they show even proper psychoeducation reduce the level of distress among patients and the family and carers. As a clinician, we can use non-judgmental approach. We should show empathy towards the patients, maintain calmness, and maintain a clear communication. We should use validation techniques. Even we can use a mindfulness training that can be helpful in various situations like managing social rejection or mindfulness or emotional dysregulation. Regular exercise has its own benefit, although there are some limitations, but exercise enhances the endorphin levels in the brain, and that also useful in reducing some of the psychopathologies in borderline personality disorder. Next. Comorbidities in adult BPD patients are a rule rather than exception, I would say. And if you see the list, there's no class system is spared where BPD is not comorbid with. As Professor Channon just said, it starts with early developmental disorders, and there's a high prevalence of early neurodevelopmental disorder, and that continued on various adult forms of psychiatric disorders. Next, please. Delineating comorbid condition from the BPD can be at times difficult, but it is not impossible and requires some kind of expertise. Some of the comorbid conditions like PTSD, anxiety disorder, improve with active treatment of BPD, whereas some of the other comorbid condition, they require active pharmacological treatment. Next, please. Crisis is a part of and parcel of BPD presentation and journey in their recovery. And this causes a lot of anxiety, not only to the family and carers, but also to the treating team. One should understand the crisis in formulating a plan and altering the risk in the future, and a collaborative approach to develop a crisis plan which is written in simple language and understandable by all stakeholders in the management. during the crisis, any clinician should maintain calm, show empathy, focus on here and there, here and now, problem solving, constant validation, and evaluating the risk. If needed, refer to specialist services or inpatient treatment. Next, please. So when we assess the risk in crisis situation, I took this slide from the spectrum, and it has been described in NHMRC guideline, that we look at high lethal method and low lethal method. Next, please. And change in the pattern from new pattern and the long pattern. Next, please. So when the presentation is with low lethal method and chronic pattern, then this situation should be analyzed and usually considered as a low chronic risk, and treatment should continue as usual with additional support. Next, please. Similarly, when there's a low lethal method, but there's a new pattern, again, it should be, one should try to understand the change in the situation. Next, please. That's where is required the inpatient treatment, where there's a new pattern and there's a high lethal method. One should consider a specialized services involvement. Next, please. Next. So when people present in the crisis, there is one should careful about suicidal risk, such as significant change in mental state. There's a recent adverse life events, expression of clear plans. There's a presence of psychotic symptoms and profound sense of hopelessness. In those situations, the risks are pretty high. Next, please. So in that situation, whether we should consider admissions, where comorbid situation requires urgent assessment and management. But however, one should be very careful. The admission should be short, brief, and it should meet the pre-identified goals. Next, please. Role of medication in borderline personality disorder is always a controversial area, and it causes a lot of discussion which way to go, what is the usefulness of medication. One should understand there's no medication patented for borderline personality disorder, and there's no consensus about their use. And we know electroconvulsive therapy or TMS do not work, although there is some reports suggest there is a modest role and their efficacy in BPD patients. Various guidelines, they recommended some symptom targeted treatment. For example, if you look at the major dimensions in borderline personality disorder, they have a dimensions of affective instability, impulsive aggression, cognitive perceptual disturbances. In those situations, there are a set of medication has been advised, or if there's a clear comorbid psychiatric disorders. Next, please. NICE guideline of UK, they say there's no role of medication and it should be limited to treat only comorbid condition. Next, please. Whereas NHMRC, our Australian guideline, they also don't support the use of pharmacotherapy as a first line treatment. Next, please. Various meta-analysis of pharmacotherapy through NHMRC guideline, they found some helpful agents like fluvoxamine, lamotrigine, or topiramate are a mood stabilizer agent, or aripiprazole as an atypical antipsychotic medicine. Next, please. There are commonly prescribed medication are antidepressant, various antidepressants, mood stabilizers, atypical antipsychotic. All have some role in alleviating symptoms, but they are not statistically significant. This is the core thing. Next, please. If you look at an article published only last year, there's a trend had changed over the years. There's a high prescription of quetiapine, mirtazapine, sertraline, escitalopram, and there's an increase in naltrexone in over the 2 decades of the prescription trend. Next, please. Whether there's any future role or future role of medication or research, there are two medications has been proposed, oxytocin and naltrexone. Next, please. The oxytocin has been proposed as main regulator of social relationship and affiliation behaviors. And in one study, the intranasal administration of oxytocin normalized amygdala activation. And you know, amygdala is an emotional center of the brain, which is highly activated in borderline personality disorder cases. Next one. And opioid system, as I was just discussing about the role of exercise. If you look at, there are various changes in opiate system in the brain, that is low basal opiate level, low beta endorphin levels, and endogenous opiate dysregulation. So that's where role of naltrexone comes in. But here, there's also important thing is there. Borderline patients, they have increased pain threshold after acute painful stressors, but they have low tolerance for chronic pain. And this should be a principle in treating chronic pain disorder with BPD, because it is a very common comorbid condition. Next, please. So general considerations are no medication patented for BPD. There are lack of consensus. It should be used sparingly and rationally. Consider safety profile, interactions with other medications, including drugs and alcohol. Medications should be used to manage crisis, but they should be stopped as soon as crisis is resolved. 25% patient, they attempt suicide with prescribed medication, and that's the major risk. Next, please. So avoid polypharmacy. One of the research recently, they showed at the time of discharge, most of the patient have been receiving more than 2 psychotropic medication. And interestingly, the type and number of medication prescribed to the patients were similar to with or without comorbid condition. So this is the trend, and this is the preference of the treating team. Next, please. Medications causes high metabolic syndromes with antipsychotic medication. There is a risk of congenital abnormalities. And as I mentioned, there's no role of electroconvulsive treatment or TMS. Next, please. Psychotherapy is a general consensus, and we heard just now is the main form of treatment. Next, please. There are various comprehensive psychotherapies, as we know, that DBT, MBT, TFT, various T-type 3-letter words. Next type. And non-comprehensive like group skill, emotional regulation, schema focused, and so on and so forth. Next, please. And we just heard from Professor Channon in Cochrane collaboration. Next, please. The DBT has been intensively studied, followed by MBT, TFP, and STEPS or STEP care program. But most of the treatment lacks a robust evidence base. Indication of beneficial effects from both comprehensive and non-comprehensive psychotherapy for BPD core pathology and associated general psychopathology. Next, please. And there's a similar study published in 2018. Next. And that also has clearly come out. There is nil significant differences in functional outcome between groups receiving a specialized treatment and treatment as usual, and long-term functioning enhanced by any kind of controlled treatment that are implemented over long period of time. Next, please. In the old days, although as we heard from the early age, now we are talking about adult, we are talking about old age, is the same. They are almost same, but there are some subtle differences. It may come up in the late life when sudden there's a change in their circumstances, like loss of a stabilizing factor, job and relationship. Even they had a very normal life without any problem, the problem of BPD can emerge in late life. Next, please. The core differences are, there are low levels of impulsivity, there's a low levels of identity problems and somatic complaints, but suicide risks are higher in this group. Next, please. There various kind of self-harm behavior which are different than the adult group, such as abuse or misuse of medication, refusal to engage in physical rehabilitation, active sabotage of the treatment, ignoring prescribed exercise advised, certain small skin picking or head banging behavior. So those are the obvious kind of differences in the mode of presentation as a self-harm behavior. Next, please. And again, management is towards the psychotherapy. It should be that focus is to establish a clear boundary, consistent therapeutic relationship and stance and approach. Next, please. BPD in parenting is another area where there's a clear differences and problems. There's an elevated level of depression. There's a more affective dysregulation. They are likely to exhibit more attachment difficulties with babies. Next, please. There is a increased risk of activation of mother's own trauma and relative high rate of poor obstetric outcome and high rate of notification to protective services. And thereby there's a cycle of, trauma, attachment, detachment cycle continues. Next. And in the children, they themselves, it has been seen, they are more emotionally dysregulated. They develop an insecure attachment style. They develop a lot of behavioral problems and poor self-image. Next. Hence, a specialized treatment approach in the very early stage is important. And Professor Channon has said, and a lot of questions has come, whether prevention is possible. Yes, it is possible when things can go from the very early part of the life. Next, please. What is the role of family? What family can do for the BPD patients? I'm sure other participants will talk. We should, as a family, we should show empathy. We should take a non-judgmental stance. We should allow the person to retain independence. We should negotiate the person in the treatment decision, balancing the family members' own need versus what amount of support required to their loved ones. Allow the person to discuss their problems and express their desire freely and to respect their wishes. Building a good working relationship with the treatment provider, sharing information with the person agreement in terms of treatment and various psychosocial issues. Next one. And coming to the end of the slide, I end this note by saying early detection and continuity of treatment for long-term provides good outcome. Medications should be used cautiously. As much as possible, they should treat the comorbid condition. Psychotherapies are the mainstay of treatment, not necessarily the fancy specialized treatments are required. We know services are limited, but there is a hope. There's a steady increase in specialized services. We still have to go a long way. Thank you. I hope I have not taken too much time.
Thank you, Yogi. We will do 5 minutes for questions so that we can give Carissa her time. I'll be the time Nazi again, Kylie.
Okay, just tell me. So Yogi, what are the main reasons for the 20-year life expectancy difference in those with BPD?
As we know, BPD patients have a lot of comorbid conditions, not only psychiatric condition. I didn't include the medical problems associated with BPD, their lifestyle, their living in the stressful situations, and use of drug and alcohol that overall created a lot of physical problems and hence early morbidity and mortality.
So Anonymous has said, would you be able to comment on comorbidity of ADHD and BPD and whether stimulant medication use has the potential to aggravate BPD symptoms, and are there alternatives if this is the case?
I would also like Professor Channon to comment on this, given his expertise in this area. But I believe these are the neurodevelopmental disorders, and that continued in the adult life. There can be comorbid condition, but most of the time, the treatment for BPD itself reduce the symptoms of ADHD in adult. However, if the symptoms are very disturbing, then one can consider psychostimulant medication in such population, but one should be very, very careful. A lot of consideration requires of the comorbid conditions. And I would welcome what Professor Channon will say about it.
Do you want me to comment?
Yes, sir.
Yeah, okay. As I mentioned earlier, ADHD actually has a strong relationship with borderline personality disorder, and they do often co-occur, even in adulthood. And there's quite a bit of work done from a group in Germany about the treatment of both conditions concurrently. I think the best way of understanding it is that the features of ADHD, although it's thought of as a disorder like depression or psychosis, it's actually more like a personality disorder. Impulsivity, inattention, hyperactivity, these are all actually traits, personality traits. And so what you find often is that young kids with ADHD, as they get older, we relabel, their impulsivity that was part of ADHD and then say, well, it's part of BPD. And so actually there's strong continuity and lots of evidence to show that the two disorders are related, and that stimulants don't tend to make it worse. And if someone does have co-occurring ADHD, stimulants can be of benefit.
Great. Yogi, so another anonymous person said her sister had a flare-up of symptoms of BPD during menopause. Have you seen this before?
As such, menopause comes with various psychiatric comorbidities, and recurrence of other comorbid condition may flare up BPD-related symptoms as well.
Mm-hmm. There's one, you and Andrew might be able to, there's a lot of people asking, how do you encourage loved ones to get help when they're resistant to getting any and don't realize they have BPD, or even when they're resistant and they know they have BPD? This is a common question for a lot of people.
Okay, I will answer first, and then I will request Professor Channon to give a finishing touch on it. This is a common situation, and it's a very interesting question. If you look at, there's one article published by, I forgot the name, but it was a kind of a live experience of patients with BPD. And they described as kind of a cycle of journey of recovery. And the first thing they described is what they call is stuck. So most of the patient at the beginning of their journey, they feel stuck. They can't move on. They think there is a problem, but they don't see any way out. And there is in that article, if you look at, they have described several patients verbatim in those situations. So I guess this particular situation perfectly fit. And it is the time and methods like what we are doing today or some other community education will promote and come out from their cell that their condition is having some hope like any other condition.
Okay, so just so that we can hear from Carissa too, I'll just quickly ask for Andrew's input and then we'll carry on with the...
Or I'll be quick. Yep. So look, I think that it's a common problem, and as I said at the beginning of my presentation, often services require so much of people to be able to walk in the door that actually it's not always the person's problem. Sometimes it's the services problem, and that we tend to try and squeeze square pegs into round holes. And actually, it's probably not a satisfying answer for you as an individual trying to get someone you love to get some help. But actually, I think a lot of the onus is on services to adapt to be able to meet the needs of people with BPD. If your problem makes you impulsive and disorganized and makes it difficult for you to manage relationships, why on earth would you expect people to turn up at exactly the right time on a particular day and never any other day, and you know, sit quietly in a room and talk to you. So I think services need to be more flexible in their approach. But I would say to those of you who are struggling to get somebody care, persist. You are going to be their best advocate, and keep advocating. And you are the only person they probably have betting on their team. And so don't take no for an answer from services, and keep knocking on the doors until someone opens one.
Okay, Carissa, did you want me to share the screen for you again?
Oh, yes, please.
Thank you.
Thank you. Oh, there you are.
You can go to the next slide. I just want to extend the acknowledgement of country. So today I'll be presenting on Boorloo land, which is Perth, Western Australia. I'd like to acknowledge that this meeting is being held on Aboriginal land and recognise the strength, resilience and capacity of Noongar people in this land and around the country. And I also want to acknowledge the lived experience people that might be on this webinar, and also the mental health professionals that are working to collaborate with lived experience to strengthen our community and help us work towards a life worth living. Okay, so I'll first talk about navigating and finding my way to peer support. So we can go next slide. I'm just gonna move. Sorry. The usual route of entering the system proved a challenging one for me. I was diagnosed at 17 and I was diagnosed in a psychiatric ward in WA. From my own experience, I was also placed straight on medication with minimal information before I was ever introduced to helpful therapies and other supports that helped me. The delivery of the diagnosis for me was very dry in terms of the way the psychiatrist did deliver it to me. And I feel like in hindsight, if it was delivered in a more positive manner, which was more strengths-based approach, it could have been a different story for me at the time. However, I'm very grateful for my journey and where I am today, and for the clinicians out there that do have those more humane approaches when delivering the diagnosis. I often stopped and started my journey. I travel okay short term, however, due to being placed within a system that was not built to meet my needs, it became a cycle that long term had a very harmful impact on my journey. I started to discover other support such as peer. So during some isolating periods in my life, I often sought out other avenues and resources on the internet, and I stumbled across people sharing their lived experience stories on YouTube. So the Australian BPD Foundation from their conferences would have lived experience people speaking about their journeys, people around the world speaking about BPD in this whole different light I hadn't seen. So that was really healing for me to find that. Therapies and clinicians do have a place in our healthcare space. However, the most refreshing thing for me with someone who has lived experience such as myself has been collaboratively working together to dismantle the discrimination and stigma that comes with the BPD label. There are clinicians and carers out there who want to work together to achieve safer outcomes for people who experience BPD. So again, over the 13 years I did experience in the system, we're definitely shifting towards a more positive avenue in terms of working to collaboratively together to, again, strengthen outcomes for BPD. Oh. Yeah. And meeting other peers in the mental health space inspired me to start my own peer support group, which leads me to the next slide. Thanks, Jenny. Yeah, I'm going now. Okay, so talking about Embracing BPD, which is a peer support group I founded and I co-facilitate in Western Australia. So go next slide. Embracing BPD is a safe, inclusive space for peers to come together and connect through shared experiences. Both facilitators, myself and the other facilitator, have lived experience of BPD, and we are both qualified mental health peer support workers. So in WA, they offer Cert 4 at TAFE to do this course that's specifically designed for mental health peer support. And it's one of the best qualifications and studies I've ever done. It was really, really intense and hard, but also quite fun and definitely challenging in the best of ways. In this group space, we mainly focus on strengths-based approach. We flip the narrative of BPD and really build on the positive attributes we have to offer, as well as acknowledging and being accountable of the negative experiences we have had. So we really unpack things in terms of how we're feeling, and we really break it down all together as a collaborative group, which is our connection in group is probably one of the biggest strengths that really helps people and keeps people coming to group. The group is flexible and people come and go as they please. So from my experience in clinical settings, sometimes the pressure to commit to every session was quite overwhelming for me and for other peers that I've met. So having the flexibility to come and go as they please has been a really good outcome for our group. We've also had some carers coming along recently, which has added a nice balance to the space to learn and grow with each other, and has been extremely healing for some of the peers in our group as well, who might not have that family support during their journey. We have grown over the last 2 years. It was founded. We still want it to be accessible, and peers are welcome to join even if they're doing therapy outside of group. So there's no way that peers wouldn't be able to access groups. So there's no barriers in that way. Our main goal is to model a person outside of a diagnosis approach. So not letting this label define us, but acknowledging that we do experience this as well. The growth we have seen peers go through has been a privilege, and that growth is the core of what keeps the group strong and connected. And this is us having fun in group. And that's our therapy dog, Monty. He's a very lovely dog. Good. I'll talk a bit about DBT and early intervention now. So DBT is dialectical behavioural therapy. It was a treatment that worked effectively with my experience with BPD. DBT was based on someone's own lived experience. So Marsha Linehan actually had lived experience of complex mental illness. And she created a module with skills and tools to help self-manage and regulate her mental health. I know it was mainly based around suicide ideation. So again, it was quite peer-based, even though it's from a clinical lens, if that makes sense. It comes hand in hand, I feel. DBT is made up of 4 components: emotional regulation, distress tolerance, interpersonal effectiveness, and mindfulness. The beauty of this therapy is that you can pick and choose the skill set to best fit your experience and the tools to help you cope and self-manage. So when I first went in, I really thought I had to get the whole module down pat, even though it's like this thick. So I had the beauty of just discovering what helps my own experience, because everyone's BPD journey is very individual. So yeah, you don't have to know every single tool or skill for DBT to have an impact, because it's very universal in terms of, I feel like it could help anyone. Yeah, I just feel like it could. I believe the great success of DBT comes down to deliverance of the module. DBT can be very intense, so making sure you have the factors such as skilled facilitators, safe environments, patience to explore the module, and time to process can be vital in the way peers take the information in. And it can help anyone regardless of the labels, which I just covered then. Embracing BPD has elements of DBT, which has been helpful in building a strong peer space. We loosely do activities together as a group that have a DBT twist, and it can be very useful for people to explore their own journeys and work towards self-acceptance. The next slide. And early intervention. I think early intervention can be helpful, again, if the right supports and resources are available. I know I started definitely experiencing some mental health distress when I was younger than 17. And even if I didn't directly have this label, I still feel like if the right supports and resources were in place, I would have been able to learn how to regulate my emotions at an earlier age. I believe flipping the script of early intervention could be useful. So redefining the DSM-5 and focusing on what people can do rather than focusing on what they can't do. So more a strengths-based approach. Peer support and early intervention would be crucial to help model recovery and for a person with lived experience to feel connected to this world. Because again, I know, again, medical and clinical has its place, but again, when you're 15 onwards, trying to learn the medical terminology and stuff like that is extremely overwhelming, especially for young people. So again, if we had some more ways to kind of communicate and use language that could really help people understand their journey a lot better, I think that could be really vital in this space. And co-designing and listening to what younger people want should be part of an early intervention as well. So having a co-design of young people's voices would strengthen their community and help avoid regular admissions into the system, such as having regular safe spaces and outlets for people to normalise and explore what they're experiencing, and also collaboratively working with the clinicians, peer support workers, just for a more strengths-based approach as well. And I think one was that. And I'll just end with, this was during BPD Awareness Week, and we had a little networking event with food, and it was an introduction into what we're doing at Group at the moment, and that was a big success. So we had roughly 30 to 40 people come through. So that was really good to see that the community is wanting to know what we're doing from peer perspective. So yeah, and that's all I've got. So thank you.
That was fantastic. Thanks, Carissa. Hopefully it'll inspire more peers to start groups up around Australia, because it's really desperately needed.
Thank you.
Carissa, if you're looking at doing Zoom groups for your peer support, then I think everyone on here is going to join. Everyone's, you know, how do we, Shandana said, how do we join your peer support group?
So I'm looking to expand online. However, I work full-time as a peer facilitator, and I play a lot of sport outside of work. So I'm trying to find that balance where I can have some more time to actually fill in a gap in the week where I can deliver it online. And me and my co-facilitator are in discussion about that at the moment. Because during COVID, I did start individually just sharing some DBT skills, and that had a really good response. So I think as the group grows and we look maybe at getting funding, because I've been asked numerous times to apply for funding, that might be something down the track, but we're just taking it one step at a time so I don't overwhelm myself and look after myself as well.
Yeah, that's a good point, Carissa. Self-care is really important as well. When you've found that balance, then it's really important to keep that, isn't it? Yeah.
Yeah, maybe if I get injured in sport, I'll start.
Yeah. So people are asking about
I wish that on you.
the individual parts. So Sydney, Melbourne, Tasmania. I know BPD Co in Australia, in South Australia, is just starting up peer support groups. I don't know what the other panelists know about what's in their state or in their area.
I'm not sure. Someone else can answer that if they want.
It's a real area that needs some work.
There are some peer support groups in Victoria, but there's also an emerging peer workforce as well. So that's the other source of peer involvement.
Carissa, Alba said, from a young person's perspective, what's the best approach to encouraging them to seek help?
I think really listening to what the individual knows. And I think this is a really hard one, because at that age, regardless of the mental health stuff you've got going on, it's really hard to figure out what you want and need and have that self-awareness. But really just really focus on what they're good at and what they know that they're confident in doing. So it might be sport, something good at school, art and stuff like that, and just really focusing on that instead of, I guess, when crisis occurs, it's really easy to just really focus on the behaviours that are going on and stuff like that. I know when people were interested in actually what I was good at versus what I wasn't doing, I was able to more focus on that and move forward, if that makes sense.
This one, Carissa, is my person with BPD recently diagnosed in their late 20s, has had a couple of hospitalizations and developed a strong dislike of group as a result of these experiences. Instead, they're seeking out friends with similar experience, but some of the unstructured nature of this is leading to connections with people in crisis and that have the negatively bouncing off each other. Would you be able to talk about the benefits in the peer support style of group?
I can definitely relate to that. Before I started as a peer worker, it was really easy to bond with people with similar experiences, but not understand the boundaries and the nature of it sometimes. So you're doing the best you can, and I think everyone experienced that. So I can definitely relate to what you've just said. In terms of group, I think if it's facilitated in a very safe and correct way, you're able to maintain those boundaries and explore friendships in a very safe and controlled manner where it won't become too much for you and you won't be taking on other people's responsibilities. Again, in peer support, you learn how to facilitate that to make sure that that doesn't happen. The benefits of group is that you connect, even if it's once a week, you still get to connect in that moment at that time with people that are going through similar things as you, and not have to have it overwhelm you or become who you are, and you can concentrate on other aspects of your life as well. That's from my experience and what I've noticed in my group as well. But if you give it a go and it's not for you, it's just all about exploring what works for you. And if that's one-on-one peer support, it could be an option as well. It depends what state you're in as well. But there is peer workers out there with lived experience of BPD that will be able to maintain that professionalism and those boundaries with you as well. So,
and I have another one, Carissa. So Jane says, my recently diagnosed 16-year-old's about to start an intensive structured DBT program. She's scared that everyone else is going to be way worse than her and will bring her down. What would you say that might help her manage that fear?
That's a good, again, it does happen. In my experience with DBT is that you learn a skill called radical acceptance, where people's journeys might not match up with mine, but I still have to validate that and try to hold that space. However, if your daughter, again, isn't ready for the intensive therapy, I'd get other resources and explore something that might be a bit more of a gentle approach. Everyone's BPD presents in different ways. Again, if you're in a safe space, it's really monitored and maintained to keep everyone safe. But sometimes even the most safest spaces, if someone's distressed, it's going to happen. And it's just how the facilitators intervene is what's going to keep everyone else safe. So I'd give it a go. But if DBT isn't for you, that's okay, because there should be other avenues to explore out there as well.
Great, Carissa. Jenny, how are we going for time?
You're right on 6 o'clock WA time. Was that 9 o'clock Melbourne time? So are we prepared to go 10 minutes over, Yogi and Andrew? Have you got 10 more minutes or?
Yep.
Yep. So should we do that? Is everyone agree that that's, and for those that are going, okay, it's my bedtime, this is recorded. It will be uploaded onto the BPD Australia.org website. Yeah, you can stop and write things down and hit play again. So it'll be a great resource, I hope. I would also ask people before everyone goes, if you've found this useful, please consider donating. All the money that goes to NEA BPD goes straight into running family connections programs and raising awareness. And we only have 2 staff members, and the rest of it is run on volunteer power. So we are getting family connections groups out there. I've said something about Family Connections in the chat, but basically Family Connections is a 12-week psychoeducation group for people who care about somebody with BPD. It is really effective at reducing the sense of stress and burden and depression and anxiety and all the things that come along with caring about someone who's in distress. So same website, get on the wait list. Unfortunately, the wait list is long, but we're endeavouring to do our best to get groups out there, including on Zoom. So back over to you, Kirsty.
Okay, so I've got a couple more questions, more general ones, yeah, that I've come across. So how common is psychosis in BPD? This can be for everyone.
I can answer first if you want. From my experience, I actually have experienced psychosis in the past. I guess Andrew and Yogi could probably expand on that, but I think it's, from my experience, it was due to the severe disassociation I was experiencing. So if I was in crisis mode and I wasn't able to regulate that disassociation, I'd start hitting psychosis point, and that happened probably a handful of times. Again, it can come across quite scary and terrifying if you haven't experienced yourself, but with the right tools and skills in place, you can definitely minimize that disassociation to avoid hitting that crisis point from what I've experienced in the past. So, yeah.
You guys, Yogi?
Yes, look, I think Carissa has put a very beautiful and explanation of psychosis from from the first-hand information and own experience. I think it is the most powerful explanation of psychotic experiences. The BPD psychosis has several layers of dimensions. So when we talked about psychosis in BPD, they can be trauma related, and they are part of the dissociation and different types of symptoms that comes in. But as we know, there are several other comorbid conditions, especially drug and alcohol dependence, and they themselves can cause psychosis. And thirdly, given their high level of adversarial situation in childhood, they themselves are high risk for developing psychosis independently on the top. So this is how I put it. But if you look at the individual symptomatology, it is the content that helps us to distinguish and the overall history. But the content-wise, most of the time, it remains the same. And many times it can be confusing. Handing over to Professor Channon.
Okay, well, we finally got something controversial to talk about. So I'm going to disagree. So actually, it's one of the really interesting areas of BPD that has really only been, there was a lot of research done about 30 years ago, and then it kind of went into abeyance. And in the last 5 or 10 years, there's been a resurgence of interest in this area. And what Carissa describes is one of the experiences, absolutely, that people can have short-lived psychotic experiences that can be, can come and go. But actually, when you systematically research this in both young people and adults, so we've published a lot of research on this area in young people, and there's been a number of studies internationally in adults with BPD. The most common experience is actually enduring psychotic symptoms, particularly voice hearing. And it's anywhere, depending on the study, it's anywhere between 20 and 50%. One of my postdoctoral fellows, Maria-Louise Cavelti, who's now back in Switzerland, did a series of studies where we looked at the experience of voices in young people with BPD. And if you put a young person with BPD in a dark room and you put somebody with their first presentation of a psychotic disorder, like a schizophreniform disorder, in a dark room, and you get somebody to interview them, they will not be able to distinguish the voices in those two people. The experience of psychosis is indistinguishable. And so often people guess about what the origins of the voices are, and people make all sorts of assumptions. And if you ask 10 psychiatrists about voices in people with BPD, you will get 11 opinions. And so the really important thing is that actually we need to bring some research to bear on this. And there's never been a systematic study of the treatment of voices in people with BPD. And in fact, we're doing the first one in Melbourne at the moment, and we're about sort of 3/4 of the way through it. lots of people will say, oh, they don't respond to medication, or they do, or but actually nobody knows. And so actually I think a lot of people with enduring, very distressing voices have been denied effective treatment because nobody's investigated whether treatments actually help. And the voices are very distressing. In fact, they're more distressing than in people presenting with schizophrenia for the first time. So it's a really interesting area, and one that I think, you know, if for clinicians particularly, keep your eye on the literature, because there's a lot of interesting work coming out.
Thank you. Is there such a thing as high functioning BPD?
Can I answer that? I really don't like the term high functioning and low functioning. From my experience, people used to box me in high functioning because at one stage I'd have a secure job, I'd be good at sport, I'd seem happy-go-lucky. But once the crisis hit and once I started experiencing severe BPD, I was just put straight back down and viewed in a completely different manner. So using the high functioning, low functioning, just for me personally, is quite a frustrating way to look at someone's mental health journey, because we're all very individual, and to put people in that box and expect them to behave a certain way, and when they don't behave that way, you all of a sudden want to isolate them. It can just be really damaging for someone's journey and trying to explore options of health. I think it just creates a really big barrier for people. So yeah.
Yeah, I think it's often used also as a way of dismissing the need for treatment. And I think, you know, functioning is, as I keep saying, it's a really important part of people's lives. You have to, it is the ball in the game, I think, in terms of making sure that people not only preserve but thrive in the development of their functional capacities. But it runs a different course to the features of BPD. And so absolutely you can get people who hold down a job and have a partner who have BPD, but it doesn't mean they don't have areas where they might need assistance.
Yeah. And just to add, it causes undue stress onto the person who is so-called, you know, high functioning.
Should we get one more question? Kirsty, you are the queen of
Sure.
the best question for the end of the night.
Okay. Okay. So if the person has a history of trauma, which they've not yet come to terms with, do they need to develop skills to cope with emotional dysregulation prior to undertaking treatment focused on the trauma? And can this happen in parallel?
I'll answer first. This is a really interesting one because during my journey, my DBT individual therapist didn't want to dive too much into my trauma, which is known as trauma-informed care, because it could have re-traumatized me and made me at more high risk, if that makes sense. I think if you're in a service or working with people that are trauma-informed, it's quite easy to explore your trauma in a very safe way. So yeah, I'd like to see more trauma-informed clinicians out there, because I know there is a few in WA, but I feel like it should be something that everyone's aiming for, even in peer support, in mental health professionals, nurses. Being in trauma-informed can actually really help your journey, and again, explore your trauma safely and recognise that you do have trauma, because I feel like everyone has trauma to some extent. It's different levels maybe, but it doesn't invalidate anyone else's experience. So yeah, that's what I feel about that, I think.
So I would really support what Carissa says, because we've saved all the hot topics until the very last couple of questions. There's a lot of discussion about trauma and BPD, and trauma is common in people with BPD, but it is neither necessary nor sufficient for people to develop BPD. So about 50% of people with BPD report developing BPD through that sort of traumatic pathway, but there's actually a lot of people who don't. And it's important to recognise the diversity of people with BPD. and also to recognise, as Carissa said, you can do excellent treatment without having to necessarily, delve back into the trauma. And there's a bit of a myth that it's, I don't know, kind of like, squeezing a pimple or something. You've, got to get the trauma out. And actually that can be incredibly harmful, as Carissa said. And so I think one of the problems in the approach, some people's approach, and where it can be harmful, where treatment can be harmful, is when people are like a kind of a dog with a bone with the trauma, even if the person having the treatment doesn't necessarily want to talk about it, and even if in the face of the evidence that person might be getting worse by, poking and prodding all the time, there are plenty of treatments that are very effective that do not focus on the trauma. Now, that's not to say that trauma is not important, but I think as Carissa said, and I just so strongly endorse those words, it's whether people want to address it and when they want to address it is really important. And I think this one-size-fits-all approach is potentially very harmful.
Andrew, I think you've just identified the next topic of our next webinar.
Okay.
Trauma and BPD. Does that sound like something that people would like to hear about? It's certainly something I'm very interested in. I almost want to sneak in a question there around, but if you talk about the effects of trauma rather than the trauma itself, about how it manifests in daily life, that can be useful, can't it?
Yeah.
Yeah. Okay, look, I almost hate ending it, but I am very conscious of time and that it's very late on the East Coast. And I just want to thank everybody for turning up tonight. I want to thank our panelists for their incredible depth of knowledge that you've all shared with us, and just encourage everybody. I'm sorry for all the questions that we couldn't get to. Please, there are many clinicians out there who are really, as you would have heard tonight, are really committed to helping in this space, and there are many peers who are committed to helping in this space. So please, if you've you've met closed doors, just keep banging on the doors until you find one that opens for you, because we're out there. The people that want to help are out there, I think. So on that note, so thank you again, Andrew, and thank you again, Yogi, and thank you, Carissa, for sharing your hearts and minds.
Thank you, everyone.
Thank you.
Thank you, everyone. Cheers.
Bye, everyone.